Good morning, dear ladies and gentlemen. I would like to present today my talk devoted to the regulating and balancing the menopause and infertility problems. So both menopause and infertility are considered as problems and disorders of the reproductive health of a woman. Reproductive health is a state of full physiologic, mental, and also social well-being of a woman, and not only the mere absence of the diseases or infirmity that related to reproductive system and its functioning. Also, it is a state when a woman can have a satisfying and absolutely safe sexual life and the ability to reproduce whenever she wants, whenever she plans. So obviously, infertility is the problem. What is common with the menopause, that it's an end of reproductive function. In case of the menopause, it can be physiologic or pathologic, and in case of the infertility, it's inability to conceive. So what is infertility? Infertility, it's inability at a couple to conceive within 12 months of time if a female partner is below 35 years old. If above 35, then this period is shortened to 6 months. Or in case of evidence of male factor, for example, infertility, the history of male factor infertility, also endometriosis or pelvic inflammation or pelvic surgery at a female partner. What is fecundability? Fecundability is the ability to conceive within 1 month. So statistically, it was calculated then that every month, naturally, at a healthy woman, the ability to conceive, the fecundability is around 20% only. So cumulative rate 93%. It happens in 12 months. That is why it is given this period of time, like one year. The biggest lifetime endowment of the oocyte, the so-called vault of the oocytes, a woman receives intrauterine in the gestation age of 20 weeks. In that time, female fetus has around 6 to 7 millions of the oogonia. By the time of the birth, it shortens or cut already to 3 millions only. And by the time of puberty, when a woman becomes fertile, it's only 300,000. So it's quite how you call it, weird that not even become fertile woman loses all her oocytes by this time. What is happening? Why this rapid loss within lifetime is happening? So by the time of menopause, which happens on average at the age of 51, 52 years old, but very common early and premature menopause. Why it happens? Because every month, every menstrual cycle, not every month, every menstrual cycle, around 30 to 50 of the primordial follicles are getting recruited to grow, compete and grow into pre-ovulatory and ovulatory follicle in the end. So only one of the maximum two grow to the mature one, so the rest 29 to 49 undergoing atresia, so totally wasted, completely wasted. The structure of infertility in the couples is next. Around 40-41% it's a male factor. The rest, 22%, it's a pelvic factor, the so-called tuboperitoneal infertility. The adhesive disease, the inflammations, endometriosis, uterine factor also falls under this category, different congenital anomalies, and so on and so forth. Cervical factor, 9%. And finally, ovulatory or endocrine factor, which is around 18 to 20%. Unexplained infertility, around 10% in the couples. But later on, it shows that this percentage is quite higher, up to 25%, not 10% as they mention. What are common factors that lead to infertility, common for both, for female and male? First, it's toxic effects. It's exposure to tobacco, alcohol, recreational drugs, and all in all, environmental or occupational hazards. Merely lack of exposure to the sun leads to vitamin D3 deficit, right? Which is actually one of the also direct factors of infertility. Another thing is calorie deficit or excessive exercising can cause in women hypothalamic amenorrhea, which is, of course, is accompanied with anovulation and ovulatory cycles, the so-called female athletic triad. I believe you know. So obesity also is quite significant factor of infertility. Many obese couples, they can show normal even parameters of the blood tests such as hormones and all, but still cannot conceive. And once they manage to lose at least 15% of the weight, they, in a majority of cases, they manage to conceive. So yeah, excessive fat, adipose tissue is a source of chronic low-grade inflammation. We all know this very well. Advanced age, yeah, this is one of the major also factors, since women currently, in the developed countries, they first of all planning career, they busy with self growth and all, and try to postpone childbirth, delivering of kids and family planning. So advanced age in reproductive medicine is currently a big problem. What kind of examination? Of course, full examination, the couple is supposed to undergo full physical examination, vaginal investigations, ultrasound of pelvic organs. For male, probably it's transrectal, for women, transvaginal. Full comprehensive blood tests, including all the hormones, maybe with the functional test also. For men, it's a sperm test and sperm functional test. For female, if it comes to this need, they're supposed to do hysteroscopy, they're supposed to do laparoscopy diagnostics, so to exclude all the possible factors, or maybe even to treat possible factors of the infertility, such as tuboperitoneal, as I said, the one we can treat only surgically, unfortunately. So as I said, unexplained infertility is considered when all the possible physical abnormalities are excluded, and all the examination findings are perfect, but a couple still cannot conceive within a certain period of time, such as 12 or 6 months, depends. So what can attribute to unexplained infertility? As I mentioned before, obesity, number one, thyroid gland hyperfunction, hypothyroidism, the thyroid stimulating hormone, which is above 2.5, as per the regenerative medicine reference range, is considered already high. So you should not look at the lab reference range. Deficits of vitamins and minerals, which is also crucial. Vitamin D, vitamin E, A, group B, B6, B12, folic acid, zinc, copper, magnesium, phosphorus, selenium, and other minerals are quite important. Sometimes probably it's enough just to address and replenish the deficits of minerals and vitamins. And already a couple managed to conceive. No need to, do any serious treatment. Immune system imbalance. For successful implantation and embryo development, it is important that the so-called decidual immune response are supposed to develop during the implantation. In case if it fails, so directly the early pregnancy loss is happening. So it was shown that imbalance in the female immune system, imbalance in the T cells types, the helpers and different subgroups. This is the direct reason why the attempts even of IVF appear to be unsuccessful and implantation is unsuccessful. So this is so-called immune type of infertility. Another type of immune infertility is quite a big similarity in partners of antigens of histocompatibility complex. So sometimes also all the causative factors are excluded, all the tests are good, but still couple within years cannot conceive. So this may be the reason is in high similarity of genes HLA system. Inflammatory lifestyle. Inflammatory lifestyle includes lack of the exercising, sedentary lifestyle, exposure to alcohol, exposure to nicotine, recreational drugs, and all in all, exposure to endocrine disruptors or chemicals that literally killing the oocytes. In different hazards that we appear to be exposed in our life cause and promote the oxidative stress. And as it also wide was shown that oxidative stress causes inflammation and causes the low quality of the sperm cells and oocytes in female. As I said, it was identified as the major pathophysiological factor of infertility nowadays. At the meantime, free radicals play, they're still important in a female body. So in a small amounts, and when the balance between oxidative stress and antioxidant defense is maintained, so they play positive role. Later I will tell more about this. In case if the amount of free radicals overwhelm female body, so it leads to the altered steroidogenesis, the impaired oocyte maturation, impaired ovulation, unsuccessful embryo development, and even pregnancy complications such as intrauterine growth restriction, preterm birth, hypertension, and all in all. Where exactly in the ovaries the reactive oxygen species are produced? In granulosa cells and in cumulus oocyte complex cells that surround the oocyte. So, and also considering the fact that oocytes are rich in mitochondria, maybe second after the muscular tissue, oocytes contain the highest amount of mitochondria, the free radicals or oxygen species producing organelles. But the physiological role of oxidative stress. So free radicals, like I said, hydrogen peroxide, superoxide anion, hydroxyl radical, hydroperoxyl, only one of those. As I said, we need them to perform the physiological processes and menstrual cycle in our body, such as ovulation, such as breakdown of corpus luteum, such as implantation, and as well as successful growth of the embryo. Where in the cell the free radicals are being produced in mitochondria on the in the intermembrane, on the inner membrane of the mitochondrial matrix. So what is happening in case of excessive exposure to factors that causing production of the free radicals, so and they're produced in reaction of transfer of electrons, so there is a leakage of electrons that form free radicals. But if we have in a sufficient amount of the enzymes such as superoxide dismutase, such as glutathione peroxidase, the major enzymes of antioxidant system, so these free radicals are being successfully neutralized. So they do not damage other molecules, do not damage the membranes, organelles, and so on and so forth, leading to disorders or diseases. So the most important to have your antioxidant system strong, and also not being exposed to mentioned above factors causing excessive oxidative stress. What is happening in the female reproductive system under oxidative stress? Lipid peroxidation, protein oxidation, DNA damage, and mitochondrial dysfunction. This is the major processes leading to disrupture in all the protein synthesis. As I said, mitochondrial dysfunction, it's like a vicious cycle. The amount of free radicals even enhance the mitochondrial dysfunction. So it totally destruct the follicles and oocytes, leading to defective implantation, altered endocrine function, and endometrial damage. That's precisely what is happening in the organs due to oxidative stress. in the tubes, which are very important. It's actually a place where the conception happening, the natural conception, the merge of sperm and egg. There is a ciliary dysfunction, so the transportation function of uterine tubes become insufficient. So the transport of even if the merge of sperm and egg is happening, is not being transported into uterus for implantation, which is supposed to happen. Growing the risk of the ectopic pregnancies. Altered tubal fluid composition also leads to high risk of ectopic pregnancies and lowers the chances of natural conception. Oocytes maturation. This is important to know. So our eggs and sperms, they have reduced amount of the chromosomes, 23, instead of 46 as other somatic cells have, right? So to get this partial 23 amount of chromosome set, the oocyte supposed to undergo meiotic division, first and second. First meiotic division is happening during ovulation. Second, during fertilization with the merge with the sperm. And this process requires a big amount of energy from the mitochondria, so big amount of molecules, ATP, synthesized by the mitochondria. And non-sufficient function of the mitochondria in terms of production of the ATP molecules leads to low oocyte quality. And later on also I mentioned the chromosome anomalies, because this energy is required for normal and smooth segregation of the chromosomes. So it leads to aneuploidias, trisomies, and all in all. During the recruitment of the follicles, like I said, from primordial, they grow, from antral, sorry, they grow to pre-ovulatory, the amount of mitochondrial mass increases in times. So from 6,000 mitochondrial DNA to 200,000 to provide the needs of future growing embryo. Mitochondrial DNA. Unlike nuclear DNA, it has a specific structure and also some specifications that should be considered. It has a circular and double strain shape, and it does not contain histones and introns, so become vulnerable to mutations, unlike nuclear DNA. Another thing that in case of the DNA damage under oxidatives by the free radicals, the DNA repair, mitochondrial DNA repair, is very poor because the enzymes are same that repairing the nuclear DNA. But for mitochondrial DNA, they work not sufficient as for nuclear. So again, mitochondrial DNA is very vulnerable to mutations. And on this picture, you can see the purple color is one of the common mutations, deletion. So you can see it almost third of the mitochondrial DNA. So it leads to major disruption of all the mitochondrial functions. And one of these functions, since it encodes the proteins that take part in the ATP synthesis, one of the consequences is impaired ATP synthesis. So again, I emphasize that the mitochondrial dysfunction leads to poor oocyte quality and unsuccessful attempts in assisted reproductive technologies techniques. So implications of the mitochondrial dysfunction. Abnormal oocyte maturation, increased rate of aneuploidias, especially trisomies, disturbed implantation, and finally arrested embryo development. What conventional medicine suggests to how to manage the couples with unexplained infertility when all the tests and there are no abnormalities like anatomical or organic dysfunction not revealed, but still the couple cannot conceive. First is the expectant management. So up to 2 years expectant management, and then following 6 cycles of gonadotropin stimulation. If again the conception not happening, they do in vitro fertilization. In case if a woman older than 35 years old, so the time of expectant management reduces to 6 months, sometimes 1 year, mostly 6 months, yeah, no time to wait. What regenerative medicine suggests? First, it's mitochondrial peptides. Mitochondrial peptides derived from the organs that take part in the regulation of the menstrual cycle, so hypothalamus, pituitary, adrenal, gonadal axis. Xenogenic origin or human origin. Mitochondrial peptides are small sequences of amino acids that able and work as bioregulators that are able to promote DNA repair and restore the normal function of the mitochondria and normal ATP production in reaction of oxidative phosphorylation. Another option is enrichment of the IVF culture with antioxidants. Coenzyme Q10, vitamins, folic acid, vitamins A, C, E, melatonin, resveratrol, and other antioxidants. The introduction of immunogenic stem cells, for example, thymus progenitors or placenta-derived stem cells or bone marrow-derived to modulate the immunity, the immune system. Another option is intra-ovarian injection of the placental peptides. Also, there are known techniques and studies of successful injection of PRP and after that successful conception. But I find that the placental peptides are a way more potent and can be more give better effect than a PRP. It is supposed to be done either intraoperatively during laparoscopy or via transvaginal injection through the wall to targeting the Douglas pouch, and of course it's ultrasound guided injection. Another option is intrauterine administration of allogeneic mesenchymal stem cells. This technique is good for women who, for example, have thin endometrium. So it appears to be insufficient for the implantation. In women with Asherman syndrome, so it's intrauterine adhesions after surgeries or inflammation or whatever. The oocytes mitochondrial substitution therapies, this is very interesting. So what they do, they transfer mitochondria from other oocytes or from the oocytes of donor to the oocyte of recipient, and therefore they augment the mitochondrial pool of the oocyte, so like enhancing the natural function and natural amount of mitochondria in the oocyte. Also appear to be successful, and there are studies on this. Administration of the antioxidants such as glutathione, superoxide dismutase, catalase, and others. Peptides, we call it biohormonal therapy. The one I mentioned, mitochondrial peptides, derived from the organ-specific stem cells belonging to hypothalamus, pituitary, adrenal, gonadal axis. Include also liver, placenta, and thymus. They work as bioregulators and perform the fine-tuning of endocrine function of the listed organs. So stimulating and modulating in case if there is a hyperproduction of the hormones, modulating their function. This is our combined formulation, more female fertility and a more HPA, hypothalamus, pituitary, adrenals. So more female fertility, it includes 5 peptides such as pituitary, adrenals, placenta, ovaries double, and liver. More HPA, as I mentioned before, the 3 peptides should be administered 1 vial thrice a week for minimum 20 weeks. These are our proprietary protocols for to treat infertility and improve the oocyte quality, improve the endocrine function, regulation of the menstrual cycle, and natural production of the hormones. Stem cells therapy, also from organ-specific xenogenic precursor fetal stem cells, either frozen, either live, administered intramuscularly via pocket system. by only one prick, and can be repeated after 6 months to maintain or even to enhance the result from the first session. The cells range that we usually administer to treat infertility include hypothalamus, pituitary, adrenals, ovaries, liver, placenta, and also thymus and intestinal mucosa. This is our very own publication on unexplained infertility done last year, done by me and Dr. Dmitry Klokal, Prof. Mike Chen, and Prof. Michelle. So there was collaborative work. One of the cause of infertility is premature ovarian failure, which another name is premature menopause. Why it happens? Due to depletion of the follicles in the ovaries before the age of 40 years old. The normal menopause, as I mentioned, on average happens in the age of 51, 52, but still from 45 to 54 is considered normal or timely menopause. After 55 is late menopause. Before, in the 40 to 45 years old, in this time is early, still early. As per the definition of the stage of reproductive aging workshop, which was reviewed in 2018, menopause is last menstruation and 12 months later, so it's retrospective diagnosis. Perimenopause is considered when women start to develop first decline of the hormones, decline of the estrogens and rise of the follicle stimulating hormone, start to have irregular menstruation until the final period. So it's a perimenopause, or also called menopausal transition, which can be early and late. Menopausal symptoms include vasomotor symptoms such as hot flashes, flushing, psycho-emotional mood swings and sleep disturbances, sexual symptoms such as dyspareunia and low libido, urogenital symptoms, vulvovaginal atrophy and incontinence, and finally, musculoskeletal. Tomorrow, I have another talk on the osteoporosis in the menopause. So pain in the muscles and joints is related to osteopenia, and osteoporosis related to estrogen decline. And sometimes there can be only the one symptom of menopausal syndrome in the absence of vasomotor or other symptoms. Genitourinary syndrome of menopause, or previous name, actually current name is GSM, previous vulvovaginal atrophy. It includes genital symptoms such as dryness, vulvar and vaginal dryness, burning, sensation, irritation, or even bleeding due to fragile mucus, vaginal mucus, sexual symptoms such as dyspareunia and low libido, and urinary symptoms, dysuria, frequency, sometimes atrophic cystitis, or recurrent urinary infections. First, number one place, of course, it's a dryness, 55% as per the surveillance and what women report. On the second is dyspareunia, painful sex, it's 44%. This is how the fragile or atrophic vaginal mucosa looks like. It's dry with petechiae. It's paler color, friable, and of course hyperemia. It's red color, and very fragile even if you insert the speculum. What is happening in the postmenopause with vaginal epithelium, also with vulva epithelium? It becomes very thin. It loses its normal layers. For example, if in reproductive or perimenopausal even age, the vaginal mucosa epithelium includes 4 layers: basal, parabasal, intermediate, and superficial. So in menopause, only parabasal and basal cells you can see in the smear, in the pap smear. So that happens due to estrogen deficiency. Same thing in the urothelium, the one that the one that make up the mucosa of urethra in bladder. what is happening at the meantime? The destruction of collagen fibers. So at the meantime, with atrophic changes can be relaxation, vulvovaginal relaxation syndrome, leading to vaginal gas, to non-sensitivity during the intercourse. So this also should be addressed. This already I mentioned the thin atrophic vaginal epithelium, that only a few layers of the cells. In the genital system, what precisely is happening? The introitus become narrow, their vaginal wall thins, their vaginal length shortens and also become narrow. So there is a lack of moisture in the vagina. So that's why their intercourse become very painful. Dysbiosis at the meantime, because there is no estrogens, no glycogen deposition in the vaginal epithelium cells, no food for lactobacilli, literally saying, so pathogenic flora get rise and propagate, leading to atrophic vaginitis problem, to dysbiosis problem, or even thrush candidiasis, and all in all. This is how looks the introitus. So you see it's very narrow, it's red and dry. So as per the studies, women who have circulating estrogens lower than 50 picogram per milliliter, they show more prominent symptoms of vulvovaginal atrophy. At the meantime, those who have normal levels of testosterone and DHEA, less common, develop vulvovaginal atrophy symptoms. So we can conclude that androgens also contribute largely to the health of vaginal and vulvar wall. Urinary incontinence. The menopause is always related to stress urinary incontinence due to poor closure of the bladder. Why it happens? Urethra is adjacent to anterior vaginal wall. So in case if it become no more elastic, in case if it become thin, so there is no support for the urethra. That's why leakage and dropping, those women report during sneezing, coughing, or exercising. That's what we call stress urinary incontinence. What are the therapeutic options from the conventional medicine? Of course, it's a hormonal therapy, whether it's systemic or topical. Also, another option is estrogen modulators, selective estrogen modulators, such as ospemifene, but studies show that they appear to be ineffective. Cognitive behavioral therapy or sexual counseling also have take place as a treatment for menopausal symptoms, including vulvovaginal atrophy. The topical treatment for this, of course, it's a creams with estriol. It's a creams with DHEA, creams with the testosterone. But number one effectiveness, also as per the studies, is still estriol and DHEA, intrarosa or prasterone, you can call it. Conjugated estrogen, like such as Premarin or estradiol ring, Novaring. Non-hormonal options, lubricants, moisturizers with hyaluronic acid, with aloe vera, with epigaline, for example. It's extract from the green tea. Vitamin E suppositories, by the way, work very, very good. Almost same effectiveness as creams with the estriol. Also, studies reveal this. Side effects of hormonal replacement therapy are very well known. In case if it was started late, not in the window of the opportunity, as we call it, or therapeutic window, which is more than 10 years after menopause onset and after 60 years old. So this hormone replacement therapy can increase the development of cancer, breast cancer, endometrial cancer, and other. That was revealed also in the studies, especially women initiative study that was done in 2002. Late hormonal therapy onset leads to increase of thromboembolism complications such as heart attack or stroke. So liver damage, of course, and shutdown of the own hormones production. In perimenopause or in women reproductive age, which, for example, develop premature menopause, are sometimes prescribed with combined oral contraceptives to manage menopausal symptoms, and they work effectively. But unfortunately, if administered, taken a long period of time, for example, more than 4 or 5 years, even this time, also may cause the shutdown of your own hormones. And yeah, unfortunately, one of the drawbacks. So what can be suggested from the regenerative medicine? Of course, device-based treatments such as laser to treat vulvovaginal atrophy. It creates micro damage. For example, if we talk about CO2 fractional lasers such as Femilift or Photona, it creates micro damage on the vaginal mucosa, promoting the regeneration, like islands of regeneration. That is why the all vaginal mucosa appear to be like renewed after laser treatment. And also, it's quite effective as per studies and what women report. This pathological comparison of the vaginal mucosa before and after laser treatment. Radiofrequency treatments such as Termiva or Indiba devices also quite effective in terms of promoting and rejuvenating the vaginal wall. They help to increase moisture. They help to make vaginal wall thicker and again more elastic. So literally improved the way. And those women report no more dyspareunia afterwards. Injectable options are also available to administer, for example, placenta onto genitals, submucosally or subcutaneously on the vulva, appear to be quite effective. So what happened? Either it's a PRP, platelet-rich plasma, either it's a placental peptides. They help to stimulate multipotent stem cells in the vaginal wall and promote the new collagen fiber synthesis and promote the glands, cells of the glands in the vaginal wall, increasing the moisture. The treatment protocol for the clitoral urethrovaginal injection. This is one of the options. So what is happening during this injection? 1 milliliter of placental peptides, for example, nano-organopeptides, 1 milliliter injected in the clitoris to rejuvenate it and to promote the blood circulation, to increase the sensation. Another 4 milliliters are administered into the space between the urethra and vaginal introitus. Very carefully not hit the urethra. So it's one side 2 milliliters and another side 2 milliliters to rejuvenate the vaginal wall and to help women with incontinence, to restore the support for urethra. Recommended 3 injections, 1 month apart, and after that maintain once in 6 or 12 months. Initially was done also with the PRP, but placental peptides are way more effective, as I said. So in total, you will need 5 milliliters only, and use the gauge needle 25, 27, even 23 can for vaginal wall, but best 25 and 27 is per what my experience. Another option is for vaginal dryness is extended, I call it extended clitoral urethrovaginal injection, when apart from injecting the clitoris and vaginal wall with placental peptides, you also go to inject the vaginal wall of introitus on the 1, 5, 7, and 11 o'clock positions. Also submucosally, very, very gentle with the tiny 27 gauge needle. Best if you can mix it with non-cross-linked hyaluronic acid, the placental peptides, for better effect. Here on the picture you can see approximately the sites where to inject. So injected in the space between the urethra and anterior vaginal wall, you promote the function of urethral glands, the one that secrete the liquid that moisture the vaginal wall and moisture the urethra, mostly. So that is how the problem with urinary incontinence can be addressed. Placental peptides, rich in growth factors, vitamins, enzymes, minerals, trace elements. So as I said, way better than autologous platelet-rich plasma. They help to stimulate fibroblasts to synthesize new collagen fibers and restore the elasticity, restore the normal anatomy. The protocol for women in perimenopause and early menopause, so we do it combined treatment. We administer systemically, intramuscularly, the peptides of hypothalamus, pituitary, adrenal cortex, ovaries, and liver. As I mentioned before, 1 vial twice a week for 16-20 weeks. And at the meantime, we prescribe laser treatment on the vaginal wall and CUV injection, clitoral uterovaginal injection. For women of menopausal and postmenopausal age, we recommend our another combo, which is female revitalization 12-in-1, which includes the organ-specific peptides such as brain, adrenal cortex, mesenchyma, placenta, ovaries, liver, heart, thymus, spleen, cartilage, bone, and fetal total. Also for 4 months, 16 weeks minimum. This is our very own publication on the biohormonal therapy done by Prof. Mike Chen and Prof. Michelle and Mitro Klokal back to 2017. Thank you so much. Maybe I told not so interesting, so nobody had understood.
Thank you, Dr. Margaryta. That was really good. So my question is, a lot of the combinations you have has placenta inside.
Yes.
And that's a contraindication with fibroids. Many women from the African demographic who have fertility issues actually have fibroids. And when you have very low ovarian reserve, we're going to be talking about stimulation. Most of them end up going in for egg donation. So if we're going to stimulate for them to use their own eggs, how do we separate the placenta from the combination?
In that case, we administer separately the peptides. First combo HPA, hypothalamus, pituitary, adrenals, that one can be safely administered. And also you take, for example, MO peptides of thymus, which would be helpful also to address the problem of fibroids. And ovaries should be also very careful, but might be promoting the fibroids. So category of women with fibroids is quite specific and should be addressed very much individually. So the combo that I mentioned is not suitable for this kind of women, definitely.
Yeah, because my question is
targeted.
We're not treating the fibroids now, we're treating the low ovarian reserve.
Yes, correct. But considering the presence of fibroids, unfortunately, placenta we should omit.
Okay, thank you.
Of course, to shrink the fibroids or the cysts, you can use the GCMF.
Yes, GCMF is another option for benign tumors. Our granulocyte macrophage activating factor, I not mention it in my presentation, but it's our proud product, which is very well sold in Europe, is popular in Europe. As I mentioned in our private conversation, it's very well demanded by doctors who work in cancer hospitals as a complementary treatment of cancers. But not only this is indication. GCMF is a bovine colostrum-based product with a lot of other supplementing extracts, which appear to be very, very good to modulate the immune system, to strengthen it, and to prevent the treat and prevent the malignant transformation in case if there is a benign tumor or cyst or fibroid or whatever. So GCMF help to shrink it.
And it works together with the thymus and the super transfer factors, just in case. Okay.
Thank
Now,
you.
do bear in mind when Dr. Margaryta is talking about the placenta for the female, we are using female placenta. Is it placenta can be male or female? What do you mean by that? That means if the fetus is a male, we will take it from the male placenta, from the male fetus. So when you do it for the male, revitalization, you use a male. When you do a female, we go for a female. So we're going into very specific, including the adrenal cortex. If it's for a male, we use a male. So we're very, very specific here because the result is better. Do understand when we talk about even the placenta, we have the fetal layer and the material layer. Okay? The fetal layer is more fetal and maternal layer. The maternal layer is on the outside. So we only use the fetal layer, which gives a better results. For the skin, you can use unisex, male and female, doesn't matter. But for your body, it's different. Thank you.
Any more question? Yes, please.
Just by using the mitochondrial peptide without the use of laser.
The mic, please. Yeah.
Do you have success too just by using the mitochondrial
Yes.
peptide without using the laser and the CUV injection?
If you're asking about fertility cases treatment, yes, only mitochondrial peptides can be already effective.
Even without the laser.
Um,
I think we have done 2 or 3 publications. You can refer back to the publication.
yes.
And the PowerPoint has shown some. And so far, we have been doing a lot of things for female. There's a lot of women who have menopause. And I say we can regenerate and bring back the menses if it's within the 1 year. This is through our experience with the stem cells or with the peptides or even with the cells. The FOC. Do understand when we say the FOC, the frozen organic cells, organocells, they only contain 5% of the stem cells. They don't contain 100%. The PSC will contain 100%. Okay? There's a lot of difference between cells and stem cells. You have 37.2 trillion cells in your 78 organs, but there are only 1 stem cells over 10,000 live cells when you're born. So when we take it from the fetus, it's 1 stem cells out of 10,000 live cells. It matters a lot. Okay? Yeah.
No more question. Okay, thank you.